Good afternoon, dear professors and colleagues. This is a very important meeting. Let me to welcome the moderators, Professor Iman Sarhan, Professor of Internal Medicine and Nephrology at Ain Shams University, and she is a well-known figure in Egypt and most probably Arab world. And I hope that Professor Omayma Saleh, because she is a senior professor of internal medicine at Mansoura University, and her specialty is endocrinal medicine and nutrition. And she established a master or fellowship in the nutrition with the German university. So I think she will join us in the second part of the talk. Today, we have two speakers. They are unique in their characters. They are talented, and their attitude is extremely appreciated and excellent. The first talk will be presented by Dr. Rasha Samir. Dr. Rasha Samir is the lecturer of nephrology in the internal medicine department, Mansoura University. And she's one of the best doctors at Mansoura Nephrology and Dialysis Unit, Mansoura University. And the talk is very exciting. Occupational acute kidney injury. This will be the first part of this Zoom meeting, and second part will be presented by Dr. Ala, and Dr. Ala will discuss a very important topic in medicine in general, in critical care, and in dialysis patients, which is total parenteral nutrition. So let us start with the first part of the of this Zoom meeting. It is my honor and the pleasure to introduce my sister and Dr. Rasha Samir. I'm happy to meet Dr. Rasha Samir. Always I feel happiness and the pleasure. So the mic is to Dr. Rasha Samir to speak about occupational acute kidney injury. I'm going to stop these slides and start the slides of Dr. Rasha Samir. Dr. Rasha Samir, you are welcome.
Thank you, Dr. Assalamu alaikum. It's a pleasure to join you through this talk, and thank you, my professor, for the introduction. I'm going to go through the topic occupational acute kidney injury or occupational acute kidney disease, which I think not widely endorsed. I think it's important, especially because the kidney as an organ is especially vulnerable to occupational and environmental exposures. It receives 20% of the cardiac output, being the main site of excretion and metabolism. And there are several complex processes of reabsorption, concentration, acidification, which all may lead to accumulation of occupational toxins with high concentration in the kidney. This is in particular in the tubular system or in the proximal tubules. Generally revising the causes of acute kidney injury, pre-renal, renal, and post-renal, we will find through these causes either pre-renal cause with hypovolemia or decreased effective circulatory volume or the impaired renal autoregulation, or among the post-renal causes or obstruction, or the intrinsic causes with glomerular, tubular, or vascular damage. Tubular damage seems to be the principal mechanism of kidney injury in case of occupational exposure. And in the vast majority of cases, acute tubular necrosis is a renal lesion that develops. It may develop hours or even days after exposure, and it is usually oligoric, and there is typical manifestations of acute tubular necrosis with renal tubular cast, muddy brown granular cast, little or no protein. Occupational acute kidney injury is important to prevent. However, it is difficult to diagnose. Why it is difficult? First, because there may be a latent period between exposure and the development of acute kidney injury or the kidney insult. The second is multiplicity of exposure, is that the individual may be exposed to multiple exposures. So defining which one is responsible for the kidney insult, it is sometimes difficult. Number three is the dosage that induce kidney injury is mostly unknown. Presence of comorbidities increase the risk of kidney injury after certain exposures, and in particular, individual susceptibility. When going through individual susceptibility, I'm going to mention the xenobiotic transporters. What's meant by xenobiotic transporters? Xenobiotics represent any foreign substance from the body. It may be a chemical substance, heavy metal, herbicide, mycotoxin, and a drug. And this xenobiotic or chemical or this foreign material is handled through uptake or efflux via certain transporters which are present in the renal tubular system. These transporters coordinate the secretion and reabsorption of these xenobiotics, and thus can modulate or prevent the accumulation of these chemicals or toxicant inside the renal tubular cells. The diversity, the abundance of these renal transporters varies from individual to another. So those persons who have decreased number of renal transporters or dysregulation in the function or dysfunction of the renal transporters usually tend to accumulate the toxicant inside the renal tubular cells, which may lead to toxicity. The diagnosis of kidney injury after exposures, some depend upon the manifest kidney injury with serum creatinine, eGFR, and some rely upon detection of early urinary biomarkers, which may be specific for the glomeruli as cystatin C, albumin, beta-2 microglobulin as marker of glomerular filtration, may be indicative of proximal tubular injury, such as the NIGAL, NAG, KIM1, and interleukin-18, distal tubules as in NIGAL or collecting tubules and the lubofenyl. Some of these urinary biomarkers are studied in different studies and reports which are targeting the topic of occupational acute kidney injury or occupational exposure and resultant kidney injury. These are the broad lines of my agenda. First, I'm going to talk about the toxins which induce occupational acute kidney injury, whether these toxins are chemical or biological, and later on infection, and the last station will be the physical stresses. So starting by the toxins, the chemical toxins, I'll start by chromium-induced kidney injury. Chromium is a heavy metal, widely used in more than 50 industries, with high exposure in those working in welding, LHAM, stainless steel manufacturing, those working in chromium plating, and also workers in wood processing. Those workers, or these occupations in particular, are exposed to chromium in large doses, and this can cause kidney injury. What is previously known and studied is that chromium can cause CKD. And if this exposure to chromium is if there is coincident exposure to lead and cadmium, this may lead to further decline of the estimated GFR. So in this study, it studies the decline in kidney function or in the estimated GFR in patients exposed to chromium with co-exposure to lead and cadmium. And here we can see two lines. The red line refers to high exposure and the blue line refers to low exposure. So the decline in estimated GFR is more pronounced with higher exposure to cadmium, especially if co-exposed with lead and chromium, especially if co-exposed to lead and cadmium. This triggered chronic kidney disease or chronic interstitial nephritis. But at the same time, chromium has been shown to induce acute kidney injury, and occasional cases of acute tubular necrosis following massive absorption of chromate have been described. This represents one of the most important occupations or jobs that expose the workers to massive absorption or large absorption of chromate. This is the industry of laser industry. Here we can see vats. These vats is filled with chromium and tanning liquor, which used to stain different types of lasers among different geographical areas and different types of animals. And however, this diversity, this traditional method seems to be the most popular form of producing lasers these days. And this photo from Egypt, Cairo, Sur Magra al-Uyun, it shows the workers who are using the chromium vats to stain the different type of laser available in Egypt. And here we can find these workers can embed large parts of their bodies inside these vats, which contains toxic doses of chromium or toxic slash of chromium, which can lead to massive absorption and acute kidney injury. In experimental models, it has been widely studied and reveals that chromate-induced acute tubular necrosis following parenteral administration of large doses of potassium chromate has been documented. And it has been found that there is extensive accumulation of the chromate salt in the proximal convoluted tubule, and there is associated evidence of a tubular damage. So as we can see in one of these experimental studies, there is an evidence of tubular damage with granular degeneration of the epithelial lining. And at the same time, there are some focal areas of necrosis of the epithelial lining with uniformly arranged regenerative renal tubules. This opened the door to some studies which study the renoprotective effect of different preparations like lactoferrin, like sodium bicarbonate and allopurinol, to study the effect, the renoprotective effect against the chromium-induced acute kidney injury. And some of these studies were promising. So disregard chromium. Coming to lead exposure, this study was published by my dear Professor Dr. Muhammad Subh and the co-authors. He studied the effect of lead exposure from automobile exhaust as a risk of nephrotoxicity among traffic policemen. In this study, he used to assess markers of glomerular filtrations and urinary markers of tubular damage and the markers of glomerular damage. And it was found that there is significant difference between the control group and the lead exposed group as regards the excretion of urinary markers of tubular damage as a NAG and also the degree of albuminuria, which suggests that exposure to lead from the automobile exhaust among traffic policemen may increase the risk of kidney injury, and this can be early predicted. In another study, the effects of exposure to mercury, which is used in dental amalgam fillings, was also assessed in healthy adults in comparison to including 80 males and 21 females in this study. And also the markers of tubular damage, glomerular damage, and glomerular filtration were assessed. It was also found that these markers of kidney damage were higher in patients who exposed to mercury in the dental amalgam filling compared to non-users or non-exposed persons. The exposure to cadmium, lead, and mercury coming from smoking was also studied in another population. And however, this result failed to find increased urine markers of renal damage in the exposed patient, but yet it may incite signs of nephrotoxicity in the presence of risk factors for kidney disease. The urinary NIGAL, there are some increasing reports which show an association between the metal fume exposure and the nephrotoxicity. And the increase of these urinary biomarkers, including KIM1 and NIGAL, was significantly associated with increased urinary levels of aluminum, chromium, iron, and the nickel levels. The mechanism by which these heavy metals lead to nephrotoxicity especially relies on activation of reactive oxygen species and reactive nitrogen species, all of which will create an imbalance between the oxidant and antioxidant capacity and will lead to injury to DNA, lipids, and proteins, particularly through disassembly of the tight junction. And here is a studied role of the calcium sensing receptors, which were widely studied in regulating serum calcium levels in the parathyroid gland. At the same time, these calcium sensing receptors particularly present in the renal tubular system and control the intracellular calcium levels, the reactive oxygen species generation, and important processes like autophagy and apoptosis, which all can prevent against the heavy metal-induced nephrotoxicity, and they can provide a future potential therapeutic option against heavy metal-induced acute and chronic kidney injury. A large number of pesticides have been found to induce acute kidney injury in human beings, some of which are herbicides like the paraquat, and some insecticide like the parathioin and indosulfan. Organic solvents, which are also widely involved in industries or in occupations like those working in dry cleaning, those using toluene or paint thinners in painting, stain removals or removers, perfumes, and those working in paving are specifically exposed to organic solvent, which were not only found to induce AKI, but also found to induce glomerulonephritis or different types of glomerulonephritis, including minimally changed nephropathy, focal segmental hyalinosis, and IgA nephropathy. So this is the first station in my talk, the chemical toxins or exposures. The second point is biological exposure. And when starting to talk about the biological exposures, I'm going to talk about snakebite mediated acute kidney injury. The snake bites are a worldwide problem or occupational hazard all over the world. The data on 2005 estimated about 20,000 deaths occur each year as a result of a snake bite. We have very serious or very toxic species or types of snakes, which renal injury can develop following bites of hemotoxic or mytoxic snakes. Hemotoxic snakes refers to snakes which inject highly venomous poison or venom, and the mytoxic snakes these are snakes which inject venom, destroying, leading to muscle necrosis, muscle paralysis, and rhabdomyolysis. So AKI can develop in both states, hemotoxic or mytoxic snakes. And it is more frequent, reaching up to 30% or 32% in some cases. The Russell viper, this one of these snakes, a large snake, an important cause of venomous or hemotoxic snake bite induced acute kidney injury in Asia. This is the state all over the world. What about Egypt? In Egypt, we have also serious and fatal snakes. They have wide inhabitants from the sandy desert up to the Nile Delta. The most popular of these snakes or most fatal is the desert deadly horned viper. This type of vipers or snakes is known by the horned viper because it includes two horns on its head. The fatality behind this snake is that it can bury its whole body under sand. So the victim cannot see the snake, and suddenly the snake attacks his victim, and the victim can only see a flash of sand moving. A flash of sand moving because the whole snake body is buried under sand. We have also the Egyptian cobra, which is highly dangerous and fatal. And one of the serious points regarding the Egyptian cobra is it prefers to live near human settlements. So it can live in villages, in agricultural areas, because it prefers easy prey or easy victims as birds or rodents. Another type is the saw-scaled viper. The mechanism by which the snake induces acute kidney injury, it first produces clinical features which depend upon the nature and the injected dose of the injected venom. The snake bite induces local pain, swelling, blistering, ecchymosis, and tissue necrosis at the site of the bite. And the commonest serious systemic manifestation is DIC, leading to bleeding diseases. Muscle paralysis and rhabdomyolysis may develop, and acute kidney injury can develop within a few hours after a snake bite or as late as 96 hours after the bite. AKI is usually oliguric with rapidly rising serum creatinine, and its persistence behind 2 weeks suggests likelihood of development of acute cortical necrosis. significant proteinuria and hematuria have been described. Exposure to snakes represent a potential hazard to those working in the Egyptian desert or in desert as general, as those working in mining, archaeology. So special precautions should be taken. The pathogenesis relies upon is that snake venom is complex mixture of enzymes, toxins, and peptides. This mixture can induce direct nephrotoxicity, can lead to altered fibrinolysis or DIC, and can lead to renal vasoconstriction or renal ischemia, hypovolemia, hemoglobinuria, and myoglobinuria with rhabdomyolysis. Scorpion sting in nephropathy. Scorpion sting, however, a rare manifestation, but all reported cases about scorpion sting in nephropathy are reported from the Middle East and North Africa. So we can find that all cases, reported from Iran, Tunisia, Turkey, Pakistan, and Israel. The mechanism by which, or the spectrum of scorpion-induced AKI, it can induce interstitial nephritis, acute tubular necrosis, hemolytic uremic syndrome, and however, acute kidney injury is the commonest nephropathy. Subnephrotic proteinuria and vasculitis were also reported after scorpion sting in nephropathy. And after scorpion comes the spider-related nephropathy. Not all the species of spiders are fatal, dangerous, but we have spiders of the genus Loxosceles, which may be fatal species of spiders. They can induce local necrosis at the bite site, can lead to intravascular hemolysis, rhabdomyolysis, DIC, and sometimes acute kidney injury develop even in patients with mild cutaneous lesion. And it represents mostly the cause of death after this accident. Most of these spiders are also present in the sandy desert. Caterpillars induced nephropathy. This caterpillar in particular, which is termed Lonomia obliqua caterpillar, is highly toxic or highly venomous caterpillar. Why? Because as we can see, its body is covered with multiple needles, and each needle of this needle contains underlying cyst or underlying sac, which contains highly poisonous or powerful venom. So each penetration of this needle to the human skin can lead to injection of high dose of venom. So the most serious complication of this caterpillar is that induce severe coagulation system change or DIC, and this caterpillar is known in Egypt since the ancient Egyptians and is described in Parsi. This is an interesting case of caterpillar-induced DIC published from South America for a 70-year-old previously healthy woman developed a sudden coma with hematuria. There is an evidence of intracranial hemorrhage. The physical examination also revealed skin hemorrhage and gross hematuria. And the most interesting is that this green caterpillar was found hidden inside her slipper. And for that, she was diagnosed based on the venom of this caterpillar. And unfortunately, the patient died 7 days after being envenomed. Regarding the bee diversity or wasp bite or wasp sting, this wasp or species of bee visit the broad beans flowers in the flowering seasons in Ismailia, Eastern Egypt, and the Nile Delta. It can induce acute kidney injury via its venom by either inducing interstitial nephritis, rhabdomyolysis or intravascular hemolysis, pigment nephropathy, and vasculitis. It represents a potential hazard to farmers and inhabitants of the mentioned areas. And now come to the sea creatures. The toxins or the venoms are not only limited to the sand, but also to land, but also land and the sea. Sea creatures may inject or may release certain powerful or toxic venoms, which naturally release these venoms or poisons to capture or immobilize their victims, preventing them from escapes like small fish and shrimps. These sea creatures, including the sea jellyfish, which are actually present in the Red Sea and represent a potential hazard for divers and those working in water sports, can release toxin faster than a gun releases a bullet. And these anemones, which are شقائق النعمان, these anemones are first described in Southeast Asia, and this is the first sea anemone whose venom has been shown to damage the kidney. This species of anemones is highly toxic, and it has been shown to induce multiple effects, including hemolysis and renal injury. And using this venom to test in experimental studies, it has been found that it induced acute glomerular endothelial injuries in rats resembling hemolytic uremic syndrome. The management of poisonous induced acute kidney injury in general, and the snake bite induced in particular, should have special consideration because about 40% of the affected patient may develop CKD on the long term. There is no specific treatment, so the therapeutic approach will be the same as that for AKI for any cause. And volume replacement, maintenance of good urine flow, urine alkalinization in patients with rhabdomyolysis, correction of electrolyte imbalance are the mainstay of treatments, with early administration of the specific monovalent antivenom and administration of tetanus, immunoglobulin, and treatment of infections. Here I come to the second part of the talk, which is infection inducing AKI. There are a wide spectrum of known infections which induce acute kidney injury in human. Among these infections, it can be bacterial like the spirochetal leptospirosis or the brucella. Can be protozoal like malaria, viral like an hantavirus or dengue fever, or parasitic as in schistosoma. I'd start talking about leptospirosis, associated acute kidney injury. Leptospira is a spirochetal infection which is transmitted to humans via rodents. The organism passes through the excreta of rodents and they contaminate water, soil, and the food. By this, it can be transmitted to human later on, either via swallowing of the contaminated water or food, or via splashing into his eyes or in through open wounds. The leptospirosis represents an occupational hazard for many people, including farmers, those which are fish workers, slaughter workers, and those are dealing with dairy products, and of course, military personnel as well. And there are published case reports describing two soldiers who fell into a river together. One of them developed the classic presentation of Wales disease as a result of leptospirosis. So these represent all risk factors for development of leptospirosis, and the clinical presentation would be either anecteric leptospirosis or the icteric leptospirosis. In anecteric leptospirosis, this happens in about 90% of cases. The patient have a first stage of prodromal manifestations, fever with myalgia, headache, abdominal pain, vomiting, and later on the patient may develop meningitis, uveitis, rash, and the fever. Here, the organism can be detected from blood, CSF, and urine. But in the icteric leptospirosis or Wales disease, which only happen in about 5 to 10% of patients, patient can develop jaundice, hemorrhage, renal failure, and myocarditis. So these are the mechanisms which describe how leptospira induce AKI. This can happen via either direct toxicity, which lead to acute interstitial nephritis, or via a variety of mechanisms, including rhabdomyolysis, jaundice with bile cast nephropathy, dehydration due to vomiting, diarrhea, or hemorrhage due to vasculitis, or vasodilation leading to hypotension, all of which will lead to acute tubular necrosis. The prevention is so important by avoiding swimming or wading in the contaminated water, using a protective coats and the gloves, drainage of the contaminated water, and rat control. The hantavirus-induced AKI. Hanta represents a big family of viruses with two known presentations. One described as old world hantavirus and one described as new world hantavirus. And both are transmitted in a similar method of transmission like leptospirosis, also via rodents, where the virus can be shedded in the excreta of the rodents and the rats and can be aerosoled via humans. The hantavirus can induce renal injury via different mechanisms, can lead to virus-induced endothelial cell damage, activation of the complement with acute tubulointerstitial nephritis, which is the most prominent histopathologic finding, and in tubular necrosis, in addition to podocyte damage, which may lead to proteinuria. The prevalence of hantavirus antibody among Egyptian patients with chronic renal disease was studied. In this study published by Professor Dr. Iman and Dr. Muhammad Subh and co-authors, they studied the prevalence of hantavirus among Egyptian patients with chronic kidney disease. About 350 patients were end-stage kidney disease patients, and about 650 patients have other types of renal disease, but with normal kidney function or with normal EGFR. It has been found that the prevalence of hantavirus in Egyptian patients was low. So among about 1,000 patients, only 12 patients had antibodies to hanta. And it seems that the contribution of this hantavirus or the association with kidney disease was also limited. Regarding dengue fever, the dengue fever, which is also caused by viral infection or dengue virus, transmitted by the mosquito Aedes or the Aedes aegypti. This dengue fever occurs in frequent outbreaks, and of course it's prevalent in Egypt or comes in outbreaks also. One of the most important, which has happened in 2017 in Upper Egypt and in the Red Sea governorates, with thousands of Egyptian patients diagnosed with dengue fever. Dengue fever can be very mild and even asymptomatic, but in many patients it can progress to a severe disease. So this is the vector, which is a mosquito Aedes aegypti. It is the principal vector for the epidemic and endemic transmission of dengue. In severe cases of dengue, the dengue hemorrhagic fever will develop with thrombocytopenia, hemorrhage, and the plasma leakage, which in more compromised cases will lead to dengue shock syndrome. So disregard the infection portion. And now come to the last step or last station, the physical stresses and its relation to occupational AKI. In this part, I'm going to stress on occupational heat exposures among farmers working in temperate zones, like in the Egyptian climate, and its relation to acute kidney injury. This study is the first study in the United States to examine the association of occupational heat exposure and the volume depletion on kidney function. This study involved 283 agricultural workers, and the researchers measured the level of serum creatinine pre-shift and post-shift. The heat exposure measurement were estimated by changes in the core body temperature, and the estimated volume depletion in workers by measuring changes in the body mass over the shift work. Agricultural workers who experience high levels of heat exposure and the volume depletion over the course of a work shift were found to be at danger of AKI, especially in workers bid by the bees. Regarding workers bid by bees, it means that some workers may do more effort and skip their breaks, their hydration and rest breaks, to gain more earnings. So those bid by bees are at more danger of acute kidney injury. In this study, the researchers identified that 35 participants with incident AKI over the course of a work shift were reported. Surprisingly, the risk of acute kidney injury was the least among obese individuals. And this was explained by the observation is that obese individuals were the least individuals to be bid by bees or achieve the least scores to be bid by bees. So they prefer to get their relaxation times, to get their rest, hydration, breaks. So the risk of AKI was less among this population. Based on the endemic of CKD, which was termed Mesoamerican nephropathy, which has been identified as a form of CKD prevalent among young and previously healthy plantation workers in Central America. And the etiology of this Mesoamerican nephropathy was unknown, but it was thought that repeated episodes of daily dehydration among those farmers or agricultural workers and the hypovolemia associated with rhabdomyolysis was responsible for the development of this Mesoamerican nephropathy. Based on this observation, several studies investigated the relationship or the evolution or progression or development of acute kidney injury in workers with permanent sugarcane harvesting. So among these studies, the presented study, which showed that those who are working in harvesting sugarcane or burning sugarcane exposed to high temperature and extreme physical work and pollutants are at more risk for developing recurrent episodes of acute kidney injury. The participants were shown to experience increase in serum creatinine, decrease in estimated GFR, and it was found that 90% of workers had increase in serum creatinine, which was consistent with a diagnosis of acute kidney injury. So the mechanism by which sugarcane harvesters or working can lead to AKI may be due to through dehydration, rhabdomyolysis, systemic inflammation, or maybe due to release of unknown nephrotoxic substance. Several studies investigated the effect of sugarcane harvesting or burning or using early predictors or urinary biomarkers like the NIGAL, interleukin 18, and the NAG, and found that workers with the most strenuous jobs, especially those working in the cane cutters and burning, has the highest increase in urinary NIGAL and interleukin 18. And workers with the largest increase in NIGAL and the NAG had associated decline in the eGFR. So the present study highlighted the markers of tubular, proximal, and distal tubular markers. Different studies focused on the working times or working hours of the day and the rest time per minute, and also differentially among different rules among those sugarcane harvesting workers. So it has been found that in those who has the highest workload had more cross-harvest kidney damages than workers with less workload. From this graph, we can see that those who are working in burned cane cutters or seed cutters have more decline in the eGFR compared to those working in irrigation of sugarcane. And this should give potential consideration of Egyptian farmers working in Upper Egypt and those working in sugarcane harvesting like in Luxor. Finally, targeting or early prediction and prevention of occupational acute kidney injury should be given special consideration to prevent AKI in general and prevent its associated or superimposed increased hospital cost and increased hospital mortality and higher risk of chronic kidney disease on the long term. So it's time to take an action, and thank you.
Thank you very much, Dr. Rasha Samir, for this excellent presentation. I am very satisfied and comfortable with your style of presentation. Although it is a very difficult task to cover all occupational related acute kidney injury. I know that you are dedicated for the literature, but I think the healthcare workers exposed to this is our occupation. And the healthcare workers exposed to a lot and a myriad of causes that can increase the risk of acute kidney injury. And nowadays we are living in the era of COVID-19. And I think COVID-19 associated acute kidney injury is one, we can consider it one of the occupational related infectious agents causing acute kidney injury. But I know it is very difficult to discuss all these issues. The environment and or occupation and the kidney is a very hot issue and a very hot topic. And in the last ESNT conference, there was a very interesting session about environment and kidney. And I remember the talk of Professor Mark Debrouille when he stated it is not acute, but he stated chronic CINAC, chronic interstitial nephritis in agricultural communities, and discovered by his elegant work that pesticides or insecticides can lead to lysosomal damage within the convoluted tubules, lesion similar to calcineurin inhibitors. Another point, if we have patients with chronic kidney disease, especially stage 5, it is better to take care of the environment, because exposure to currents bad currents of weather may precipitate pulmonary edema and fasten or increase the necessity for doing dialysis. I like your talk about acute kidney injury, CKD continuum, because acute kidney injury leaves its print on the epigenetic pathways that may increase the risk of chronic kidney disease. This is why all exposure or occupation-related kidney injury, the best management, as you mentioned clearly, is to avoid prevention. And I want to end my comment by a funny comment. You mentioned snake. Not all snakes are poisonous. And we are rushing to give snake venom, anti-snake venom. The patient may suffer from anaphylaxis. So when we have the Samanood branch of urology and referral center, because it is among the agricultural communities, and there we found snakes. So how to avoid the snakes? Because we are not sure of the nature of the snakes. What we did is we used the common sense, because we found that a certain type of plant, I didn't know the translation to English, sheah. When we put sheah in the area, it was natural repellent for the snakes. And after putting this sheah, we didn't find any snake anymore. At the end of my comment, I'd like to thank and appreciate your presentation. And now it is open for discussion. And I hope that Dr. Mu'tasim unmute Dr. Iman Sarhan.
Thank you, Dr. Hussein.
Iman?
السلام عليكم دكتور حسين. انا مش لاقي الدكتوره ايمان، لو هي موجوده بس ايمان بعد اذنها.
One of the professors and colleagues wanted to have any comments, please unmute him, Dr. Mu'tasim.
السلام عليكم.
وعليكم السلام.
دكتور حسين، طبعا I would like to thank Dr. Rasha Samir for her elegant presentation. He make يعني outline for most not all the occupational acute kidney injury. I think she handled it very good and very nice. Maybe not all like Dr. Hussein Sheashaa addressed, because it is a lot of, it cannot be يعني gathered in one lecture, but she did a very good job. And I think it's make it easy to be handled for other who يعني to communicate all the prevalence. She make the vision good, and I think she make highlights very good. I have no comment for her lecture. It's I think it's very elegant.
Thank you very much.
Dr. Rasha.
Thank you very much, Professor Iman. Now we have Professor Riyad Saeed.
مساء الخير.
مساء النور.
أهلا. الله يخليك دكتورة رشا. You did a fantastic job for the time allocated to you. Really, you covered a lot of these things. I'd like to comment only on the occupational hazard that really we have in our area. Here in Jordan, we have the Dead Sea area, which is a very hot, humid area. Agricultural people who are working there, even we have faculty of agriculture, usually we send our students there to work in the farms, belong to the university. Heat stroke is a major hazard for such individuals. They come to us with acute kidney injury due to rhabdomyolysis. We encountered good number of our students, and that's, you know, now we are implementing more and more precautions for that. Secondly, you know, also in new recruits in hot, humid areas, Remember, we have a couple of patients who came to us from Al Hudaybiya, Yemen, which is a high altitude and humid on the Red Sea, with occupational hazard. You know, when they start going into the army, you know, they are developing really heat stroke with acute rhabdomyolysis. Overall, I think the lecture was a very good educational one. Thank you.
Thank you very much.
Thank you very much, Professor Riyad. And you remind me by the issue of heat exhaustion and rhabdomyolysis. Yes, maybe encountered in Hajj, maybe encountered in sports medicine, may be a part or a problem of the armed forces and doing heavy exercise for unacclimatized personnel.
That's the newly recruits اللي هو المجندين الجدد.
Yes, yes. Thank you very much for these very nice points. Professor Omayma Saleh. Thank you, Professor Riyad.
Thank you.
I would like to thank Dr. Rasha for her very marvelous presentation. I have a comment. I heard her talking about chromium toxicity. And this is, I didn't say which dose affecting, because it's chromium supplementation, although it's a trace element as all we know. Chromium supplementation is widely used because many patients think that it improves insulin sensitivity, and they use it on obesity management and so. I think the dosage used is very low, but I wanted Rasha to explain how the patients could be exposed to chromium and for how long to develop this affection. Secondly, I would like to comment on the snakes. Of course, the majority of the snakes are non-poisonous, and there are ways to know which snake is poisonous and the other. And the character of the non-poisonous snakes are different from the poisonous snake, and the bite itself, which is composed of fang marks, not teeth marks, and the skin over around this the bite becomes a change in color, and there is intense pain at the type of, or burning pain at the time of the bite itself. Something else, it's called for not to be have very severe phobia from the snake bite. The snakes, there is something called snake bites, especially for the cobra, although because the cobra sometimes can eat, and sometimes when they bite someone, the bite could be called dry bite without any poison in it, in about 25% of the cases. The more dangerous snake is the snake that Rasha told us about it, which is very ruthless snake, and they call it قرون الحياة المقرنة. مشهورة قوي عند الناس اللي في الحتت اللي هي الصحراء وكده يعني. شكرا دكتور حسين، وشكرا لرشا طبعا.
Thank you very much, Professor Omayma. Regarding the first point, Dr. Rasha, chromium.
Regarding the first point, regarding the dosage of chromium, which is causing acute kidney injury, because I got through literature in acute kidney injury, the studied dosage is studied only in experimental models. 20 milligram per kg per day or 30 milligram per kg per day of potassium dichromate salt injected into experimental animals. But regarding the doses which lead to acute kidney injury in particular, the dosage in human are not determined or not known.
Yes, and regarding mercury, as you know, nowadays it is prohibited to have mercury, even sphygmomanometers and thermometers and whatever, because to avoid the problem of mercury. Okay. Then again, the second point, I think you clarify the types of poisonous, and as I mentioned, when we have the branch of Samanud, and I was responsible about the place at that time, and the problem was I was afraid to give any person the anti-snake venom because I was afraid of anaphylaxis from this anti-snake venoms, and I am occupied by the type of poisonous in this area is type of snakes in this area is not poisonous. So when I found the idea of sheah to be used as physiological repellent, I was very happy because we didn't find snakes after putting sheah within the asar al-zara.
This is nice.
Okay, Dr. Ahmed Aql, thank you.
Assalamu alaikum. I would like to thank Dr. Rasha for this excellent presentation and the difficult one actually. And we all neglect this during clinical practice. And I think the key point in all occupational and environmental kidney injury is the history. History taking, just history taking can clarify 90% of the cases. And from my experience, we have published during the last 14 months 3 cases. One related to hair dye nephropathy in young female, which was new for me to be confronted with someone having a kidney injury from just dyeing her hair with the famous creatine, and we found that it was the main transmission through inhalation of the creatine dye in poorly ventilated place. And the second case we have published also related to gym nephropathy, which also new for me and new environmental hazard that young males can go to the gym as we are guided them to practice healthy life, and they at the end can have kidney injury from malpractice by taking anabolic steroids, taking a high dose protein diet without good guidance from the trainers, and instead of doing fitness, they do bodybuilding in wrong way. The third case, as Professor Hussein said, in CKD patients, especially advanced one, also can have environmental abnormal presentations that cannot be belong to normal population. Like we have a case published just 2 months ago with Khilla nephropathy. Khilla is a famous plant used by pharaohs 4,000 years ago to control renal infection and stone disease. And it is when you do search for Khilla, it is a marvelous plant for kidney. But this man, he is old man with CKD stage 3. He found the information through the internet and started to boil the khilla and drinking it routinely every day, and came with interstitial nephritis. So actually all of this is away from the routine practice and can make a lot of difference when we identify such cases. So I would like to express my gratitude and thanks to you. I learned a lot today. Thank you very much.
Thank you very much, Professor Aql, for all these 3 case reports. Fantastic, congratulations. And I agree with you because we have cohort here with Professor Nagi Abdelhadi, when he noticed that use of certain hair dyes aggravate lupus nephritis. So we should be careful about the hair dyes and to be sure that we are using brand types and not, because there are some famous types like black henna that can lead to multiple organ dysfunction. So this is a very interesting and a very exciting point. I also was confronted with a case, young man who drank a lot of the power, the مشروب الطاقة ما أعرفش اسمه and was complicated by some sort of acute renal failure, and the biopsy confirmed rapid crescentic glomerulitis. I'm not sure, I cannot swear that مشروب الطاقة is the cause of crescentic, but this was an association from this case reports. And I remembered one of our publications, a review article about Plasmodium. We are lucky here in Egypt because we don't have a high burden of malaria. Because in some areas in the world, malaria is the most common cause of acute renal failure. So if we say single cause of acute renal failure, the most common single cause of acute renal failure worldwide, it is malaria. But here in Egypt, the majority of malaria cases were imported from outside. Thank you, Professor Aql, for your cases. And if there are any comments, please, anyone want to add any comment, raise hand. Dr. Saeed Khamis. بروفيسور سعيد اتفضل.
شكرا يا دكتور رشا على المحاضره الرائعه. طبعا زي ما قلت لحضرتك دكتور حسين it was very difficult to cover all the aspects of occupational acute kidney injury, but just one point, she mentioned already this point, but I would like to highlight this point, this toluene-induced acute kidney injury. Toluene used in the dye painting the walls of the buildings and so. And also it can lead to severe hypokalemia and metabolic acidosis. And I faced one case with this complication due to hypokalemia and presented with severe muscle weakness. And when we reviewed the history, as Professor Aql said, we found that he is a worker in painting of this building. So we could manage the case in a proper way. So history taking in such way, it's very important to save the life of these patients. Thank you, Dr. Rasha, and thanks for all.
Thank you, Professor Said, for the toluene statement, because in the CGS, and there is a very nice case report, toluene can be used to be smoked to raise the mood. And there is a severe case of metabolic severe acidosis complicated with hypokalemia. If there is, and it was metabolic, high anion, normal anion, and respiratory acidosis, triple acidosis, plus severe hypokalemia, serum potassium 1.8. So if we correct the acidosis, this will lead to profound muscle paralysis, even cardiac necrosis. So that we can start with treating to stop toluene abuse for those who abuse the toluene, and to stop exposure to those exposed to toluene, and then to correct hypokalemia first, and then the issue will be it is very nice comment to Dr. Said. Thank you very much. And I think it is now 1 hour, and I would like to say to Dr. Rasha Samir, excellent presentation. I am very proud of you, Rasha. And the last point I want to emphasize, in agreement with Professor Ahmed Aql, history is very important. We should take history, as we say, drug history, family history, occupational history is important, and usually we neglect occupational history. It is very important because it may be the clue for presentation. And if you remember my comment about the history in one of the previous presentations, the quotation of one of the philosopher who mentioned that history is a fundamental part of medicine. If you don't take history, you're like a leaf. This is a statement, like a leaf doesn't know it is a part of tree. So history is important, examination is important before we jump into investigation. The most important management strategy is to avoid and to prevent. Thank you very much, Dr. Rasha, for this excellent presentation. It's very satisfactory, and it will be uploaded, inshallah. Thank you very much.
Thank you.